Hello, my name is Mara Koffmann, and I'm the co-founder and CEO of Braintrust. We are a marketplace where parents can connect with certified teachers and learning specialists for private tutoring support and learning interventions. And I'm here today with Dr. Al Ravitz, who also happens to be my father. And
That's what I was going to say when she said I was going to introduce myself. Okay.
why don't you tell us a little bit more about your background?
Okay, so I'm a child psychiatrist and a forensic psychiatrist. I've been at this for about 40 years. I've done a lot of psychotherapy, a lot of pharmacologic assessment, and a lot of diagnostic assessment. I've consulted with schools. I was on the faculty at the University of Chicago for about 30 years, and then for some reason we decided to move to New York. I think it's because my daughter was at NYU at the time. In any case, I then worked at the NYU Child Study Center and then at a place called the Child Mind Institute, where I was a forensic psychiatrist and a pharmacologist, and now I'm in private practice.
And given that wealth of experience, I figured Al would be a good person to ask about ADHD, because it is such a frequent diagnosis and something that parents and students hear so much about. So let's learn about it from an expert. So first question, I think, is what is the cause of ADHD?
Well, I don't think anybody knows exactly what the cause of ADHD is, but like every other psychiatric illness, there are probably genetic components and environmental components. When I diagnose kids with ADHD and then I ask their parents various questions, I would say at least 50% of the time it turns out that mom or dad also has ADHD, sometimes diagnosed, sometimes not diagnosed, but that speaks to a kind of a genetic predisposition. Now, given the frequency of ADHD, I think that you also have to look at whether or not it is in some way or another environmentally determined. So we live in a culture where kids from the age of, say, 5 to the age of 18 have to sit in a chair and listen to somebody for 8 hours a day. This is not exactly the way that evolution has programmed us to sit and pay attention to one person for 8 hours a day. When I talk with families and when I make a diagnosis of ADHD, they always say something like, is this going to go away? Is this going to be there forever? And then when I prescribe meds, the question is my kid going to be on meds for the rest of his or her life? Most of the time it's his. It's more frequent in boys than in girls, but sometimes her life as well. And the answer that I usually give, the answer that I always give, but sometimes I have to elaborate on it, is that, number one, it looks as if some of the issues with hyperactivity go away during adolescence. But the issues that are related to attention are typically there for most of a person's life. But when you look at attention in ADHD, there isn't a global deficit in the capacity to pay attention. It's not like you can't pay attention to anything. It's more like you can't pay attention to the things that don't interest you. So the answer to that second question about, is my kid going to need meds? My answer is that it depends on what your kid does when your kid becomes an adult. If your kid decides to become a certified public accountant, it's altogether possible that he or she may need medication for the rest of his life. But if your kid decides to become a filmmaker or an artist or an entrepreneur, a lot of those people don't need to take meds because they're doing things that really interest them and they can attend to those things. You talk to parents who have kids with ADHD and they'll always say to you, well, but he could play video games for 4 hours a day. And yes, because that's interesting to a kid. And those video games are they're designed, they're engineered to capture the attention of people who have limited attention spans. So the answer is, it probably has to do with attention. It probably has to do with culture. So if you're in the right kind of culture, you may have ADHD and it'll never be diagnosed because it's kind of irrelevant to your adaptation in that specific culture.
Mm-hmm. And in terms of the prevalence of diagnoses these days, do you think there's a reason why more and more kids are getting diagnosed with ADHD? And do you think it's happening with more frequency than is true sort of in reality for these students?
So that's a question that's in the psychiatric literature. People address that one all the time. And there is a possibility that because there are so many toxic chemicals in the environment these days, the frequency of ADHD is slightly increased. But most people believe that the reason that there's an increased frequency of ADHD is because we are more sensitive to the diagnosis. I would say, however, that, and when the DSM-5, the Diagnostic and Statistical Manual for Psychiatric Disorders, that's the American Psychiatric Association's it's like a menu at a Chinese restaurant where you choose 2 from column 1 and 3 from column 2 and 2 from column 3. It's how do these diagnoses turn into certain types of clinical syndromes. In any case, when the DSM-5 was released, which is maybe 10 or 15 years ago, I don't remember the exact date, the frequency of ADHD was approximately 5% of the population in the US. The frequency is now estimated to be about 10%. If you look at European countries, the frequency is much less. So it's got to do with diagnostic criteria, it's got to do with diagnostic sensitivity, and it probably has to do with the culture's acceptance of the diagnosis. So people with ADHD, it's so common that these days it's not so bad to have ADHD. 50 years ago, when the diagnosis was very, very rare, the idea of ADHD meant, oh, this is a very serious problem. We have pretty good treatments for ADHD these days.
And so, the stigma around diagnoses is disappeared, and so therefore...
Disappearing.
Yeah.
Yes. Yes.
Do you also think that the nature of the classrooms now and sort of the expectations that there's less play-based experience, there's a lot less kind of like project-based learning types of activities, and there's a lot more sitting down and listening and doing the sorts of activities that are not as inherently interesting, and so that could heighten a teacher's sensitivity to these sorts of behaviors?
I would say there's no question that that's the case. Yes.
Yeah.
Right.
Something to be mindful of for us teachers. And a question that I think I hear a lot from parents is, I don't want my child to be on medication. What are some alternatives to medicating my child, especially my young child? So, what are the pros and cons of medication, and what are some alternatives if a parent doesn't want to explore medication?
Well, if you look at the American Academy of Pediatrics recommendations, they say you should try a non-pharmacologic approach in children below the age of 5 or 6. Now, what are the non-pharmacologic approaches? They're primarily parent training and teacher training programs. They have to do with identifying problems and then decreasing the frequency of the expression of those problems, primarily through positive reinforcement, but also through some limit setting. Mm-hmm. So there are a variety of different structured training programs. There are probably 5 or 6 of them, and they've all been shown to be reasonably effective when it comes to modifying behavior. But when it comes to modifying core deficits, the core deficits of inattention and impulsivity, probably they're less effective. The biggest study on ADHD was something called the MTA, Multimodal Treatment of ADHD, which was a study that was done probably 10 years ago now, or maybe even 15 years ago, that involved a number of different research institutions. And what that study found was that the combination of medication and some type of parent training intervention was the most effective. The second most effective was medication alone. The third most effective was a non-pharmacologic intervention. Now, I should also add that these days there are all of these new technological types of things like neurofeedback, and there are some games, and there is this program called CogMed, which has to do with working memory. The research on neurofeedback, based on an article that a pre-publication article that's going to be in the Journal of the American Academy of Child and Adolescent Psychiatry, basically says that there isn't a lot of evidence that neurofeedback is effective. Now, if there is some anecdotal, that means like some people will say that it's been very, very effective for them. I've had families that have utilized neurofeedback and have been very pleased with it, but the degree to which it's a placebo response, because when you look at what you do when you're studying neurofeedback is that you're looking at, you connect certain types of electrodes which are supposedly reading the shape of your brain waves. That's what neurofeedback is, and you train yourself to have more beta and less theta, okay? I mean, I'm not going to go into all of the details there, but they also do a sham thing where they also connect electrodes, and they also look at the shape of your brain waves, and that's where the problem comes in. It's that the difference between the placebo response and the real intervention is insignificant. So you get improvement with both placebo and with real neurofeedback. So what does that say? It probably says that it's not the neurofeedback itself, but rather the intent that makes the difference. Okay? People have also looked at diet. For all of you out there, I know you're not going to believe me, but I'm going to tell you anyway, sugar has no effect on hyperactivity or attention.
And this
okay?
coming from my father, who constantly gives my kids lots and lots of sugary treats at all times of day without any concern.
That's so not true. I give them fruit, I give them vegetables.
And chocolate chip cookies.
And chocolate chip cookies, yes. There you go. All right, but people have looked at diet, and it does not, the only finding that seems to be scientifically validated is that there are certain food coloring that that may have a negative influence on attention. But other than that, I mean, there's no data to support the assertion that sugar interferes with attention or increases hyperactivity.
And what about the impact of yoga or mindfulness training? Are those shown to be effective?
Nothing. It's very difficult to do this kind of research. So the studies are very small, and usually what you find is there's a placebo response in addition to an active treatment response. But there is some data to suggest that yoga and mindfulness may be helpful, yes. But the most helpful non-pharmacologic intervention is parent training. Teaching parents to identify behaviors, to positively reinforce adaptive behaviors, and to somehow or another, I mean the technical term is to punish, but to decrease the frequency of behaviors that are not helpful.
And how do executive function skills fit into the sort of overall picture of a child who has ADHD?
Okay, so maybe very briefly, executive functioning has to do with how we organize our perception of the environment, how we prioritize the various factors that should influence our decisions, and how we then make rational as opposed to impulsive decisions. Okay, there are several different definitions of executive function. Russell Barkley, I think, has 4 criteria, other people have 7 or 8 criteria, but it all has to do with organization, prioritization, and creating a kind of hierarchy of what's important, and so what should I focus on now? How do I make this decision now in a rational sort of way instead of in an impulsive sort of way? And Russell Barkley would say that it's the executive functioning problem that underlies ADHD. I will say that most of the kids with ADHD have problems with executive function, and also it looks as if behavioral treatment and educational treatment is probably more effective specifically for executive functioning than medication. Medication is very, very effective in terms of improving attention, in terms of decreasing impulsivity, in terms of decreasing distractibility, and in terms of decreasing hyperactivity. But there isn't really any evidence that medication is helpful, for example, with working memory, nor is it helpful in terms of the larger issue of executive function. So what that means is that some kids who have mild ADHD will do just fine on a touch of medication, but most of the kids who have ADHD need more than just meds. They need a specialized educational program, and they need parent training.
Yeah, and with the executive function skills, what a good instructor or interventionist will do is work to really address how to effectively set goals and how to monitor performance and how to learn from experience.
And see, all of this is self-awareness,
Yeah.
which is like one of the core deficits when you have an executive functioning problem. You have impaired awareness of self.
And the inflexibility too.
Yes.
Because that flexibility and being able to solve problems in a different way is such an important part of being able to move forward and learn how to solve problems in a better way.
So that has to do with being able to defer action until you can rationally assess a problem rather than just reacting impulsively.
Mm-hmm. But what about the challenge of figuring out an alternative solution for a given problem with sort of this, like, not necessarily a fixed mindset, but a lack of creative problem-solving abilities?
You're saying, I'm not sure I understand your question, but what I think you're saying is kids fall into certain types of habits, mm-hmm. and then human beings have a tendency. You talk about creating the problems that you have, okay? People have a tendency to affiliate with other people who have similar predispositions. They have a tendency to only pay attention to information that already reinforces their pre-existing predispositions, and they get a little bit nervous if suddenly things are going better, and so they begin to behave in ways that evoke the response that they anticipate, okay? This all has to do with teaching. So it's very difficult for people to learn to address, well, it's not so difficult if the problem is relatively new. It becomes more difficult the longer the problem has existed. So yes, that's exactly what the intervention has to be. It has to be something like, take a look at what you do, all right? What you've done up to now has just created misery for you. You're failing in school, all of your teachers hate you, your friends feel like you're too intrusive, your parents are always upset with you. Take a look at that, and let's figure out what you do when you encounter a certain set of environmental variables, and let's try to change your response to those variables. Let's try to, in terms of cognition, let's try to change the way that you interpret that. And then let's do a kind of test. Let's generate a series of hypotheses about what might happen if you behave differently, and let's test those hypotheses. Now, I leave that in the hands of educators. This is not so much, this is not specifically what I typically do. Usually I refer to a psychologist to do that type of intervention, or I consult with the school and talk to the teachers about doing those types of interventions. Some teachers are really open to that idea. Other teachers they're more cynical about
Yeah, well, and I think it goes back to that idea of, thinking about instructional style that's going to be more supportive of a student and having to adapt that classroom experience to provide the support that the child needs in order to succeed. But it can feel frustrating at the same time for parents and teachers alike to just see this kid that constantly doesn't seem to listen or doesn't seem to get it or doesn't change.
Which is why medication is so helpful, okay? Now, I really don't own stock in any pharmaceutical companies. I'm not part of any kind of pharmaceutical industrial complex. My experience over the last 40 years of being a child psychiatrist is that medication works remarkably well to take care of certain things like attention, impulsivity, hyperactivity.
And what are the cons to medication for those families that choose to explore that route of treatment?
Okay, so most of the time the cons can be managed, all right, by changing the duration of action of a medication or changing the time when you administer the med, things like that. But what are the cons? Sometimes when people are over-medicated with ADHD meds, with stimulant meds, they become hyper-focused, they lose their emotional peripheral vision, and they look like robots. Parents are always saying to me, I don't want my kid to turn into a zombie, and I always say, that's exactly, no, I always say, of course not. We've got to find the right type of medication combination that's going to prevent that. So that has to do with, and some kids just don't tolerate the meds. They hate the way the meds feel. Most kids really like these meds. They feel that they're very helpful and they like taking them. What are the common side effects with stimulants? The most common side effect by far is decreased appetite. Usually that goes away. If these meds really worked to decrease appetite, they would be marketed as diet pills, okay? FDA does not allow them to be marketed as diet pills. Some of these meds, Adderall initially was a diet pill until a new pharmaceutical company bought it, rebranded it, and remarketed it. But it was initially, I think it was called, I don't remember what it's called now, Dexatrim or something like that. Decreased appetite for sure. Usually that goes away within a couple of weeks. If it doesn't, then we have to think about how to be more creative. So most of the meds that people utilize these days are long-acting medications. The reason that they utilize long-acting medications is because there's a smoother onset and a smoother offset. But in addition to that, kids don't have to go to the nurse's office in the middle of the day. And sometimes kids are embarrassed or stigmatized if they're taking meds. Okay, but when you take long-acting meds, oftentimes these kids aren't hungry at lunchtime. And if they're not hungry at lunchtime, that can create a problem, okay? So, decreased appetite for sure. The next problem is decreased sleep. Sometimes these medications interfere with the capacity to fall asleep. The longer-acting meds have more of a problem with this than the shorter-acting meds, but even the longer-acting, most of the time this isn't a problem. Sometimes it is. If it becomes a problem, that necessitates a more creative approach to what to do. Some kids feel nervous on these meds. And then people talk about a kind of rebound phenomenon. So when the medication wears off, sometimes you see an increase in impulsivity, an increase in hyperactivity. Sometimes you can see some irritability, and you often see inattention and distractibility. The longer-acting meds have a smoother offset of action, so you see less rebound with them than with the shorter-acting meds. But again, these things typically can be managed by generating a kind of more sophisticated medication intervention strategy. Now there's one other side effect that you see with stimulant medications, and that's the presence of tics. Things, not Tourette's, but what's called just a tic disorder. So, and tics are sort of, usually they're facial twitches or throat clearing or certain types of neck movements. Now, the question of whether or not stimulant medication causes tics is a complicated question, because tics and ADHD, there's something that's called comorbidity. That means you have more than one diagnosable disorder at the same time. The frequency of tics in kids who are diagnosed with ADHD is something like 40%. The incidence of ADHD with kids who have tics, if you're initially diagnosed with a tic, the incidence of ADHD is huge. It's really high. For a while, people thought that the scientific practice was that if someone develops tics, then you have to discontinue the medication. But more recent research on this seems to indicate that some kids do better when they're on stimulants, some kids do worse, and some kids are unchanged. My general practice when someone develops tics is to try to discontinue the medication and to utilize another type of medication that doesn't cause tics and see if that's effective. But ultimately, a lot of families end up doing a cost-benefit determination, and they end up I've got one kid, and every time I see this kid, I get nervous because he's got tics, and I keep saying to the family, we've got to get him off of these meds. And the family says, we've tried him off of the meds. The damage to his self-esteem from his ADHD is so much worse than the damage to his self-esteem from the tics that we would rather continue the meds. I keep doing what's called an informed consent with them so that I can document that I've discussed this with them and that this is the decision that they've made. So right now, it's up in the air as to whether or not these meds cause tics. If there is a family history of tics, then I'm very careful about starting a kid on a stimulant medication, because the risk of tics is much higher when there's a family history. It also merits mention that tic disorders, they wax and wane. That means they get better, they get worse, they get better, they get worse. And usually tic disorders are most frequent from about the age of 8 or 9 to about 17 or 18. And then they often just decrease in frequency spontaneously, or they disappear altogether. If kids develop tics, there are really, so the stimulant meds are the meds that cause tics. What are the stimulant meds? The stimulant meds are drugs like Adderall and Concerta, Ritalin, Dexedrine, Metadate, Vyvanse. Some of them work by increasing the concentration. They all work by increasing the concentration of dopamine in the central nervous system. Some of them are they're variations of dextroamphetamine, and some of them are variations of a medication that's called methylphenidate. Methylphenidate is the Ritalin type drugs. Dextroamphetamine is the Adderall type drugs. They both increase the concentration of dopamine. Some people do better on one than the other. Most of the time, I will start a kid on a methylphenidate type drug, a drug like Ritalin, or the long-acting version of Ritalin these days is Concerta. There's also a new Ritalin type drug that's really kind of amazing. It's called Jornay. You give it at night and it kicks in the following morning, because a lot of times people who have kids with ADHD, the mornings are really chaotic and there's a lot of conflict because it's hard to get the kids ready for school. You give Jornay and it kicks in about 8 or 9 hours later. So some kids wake up and the medication is already at work. I think it's a very interesting, I don't have a lot of kids on it. Most of the kids that I treat are on Concerta or Vyvanse. Vyvanse is the dextroamphetamine type medication that has the longest duration of action. Concerta and Vyvanse have interesting, they're technologically interesting medications in terms of the way that they release the active ingredient into the bloodstream, and they have a pretty smooth onset of action, and it stays like this. Some of the other long-acting drugs are more like this, but those drugs just stay just like that, and then and you can't see, and then they end up fading out like that. Okay, so I like Concerta and I like Vyvanse. They each have durations of action of between 10 and 14 hours. And that's that's enough time to go to school, to come home, to do your homework, and then to not need any medication later. I do sometimes have to give boosters. Okay, having said that, there are other kinds of medication that you can use to treat ADHD. There are drugs that are called alpha-adrenergic agonists. These are drugs like Intuitive and Capve. The generics, it's guanfacine, and clonidine, okay? They utilize a totally different mechanism of action. They have been shown to be helpful for ADHD. I think my clinical experiences, they're more helpful for the hyperactivity and impulsivity than they are for attention per se. But if you look at carefully designed clinical trials, there probably is some evidence that they can be helpful in terms of attention as well. They never cause tics, and in fact, sometimes we use those specific medications to treat tics. The problem is that they're somewhat sedating, and kids complain of headache and irritability on those meds. You give them at night one of them, I always get mixed up. I think it's Intuitive, you give twice a day. Capve, you give once a day. Capve, they say give it in the morning. I always give it at night because these drugs help with sleep because they're a little bit sedating. But they don't work as well, and figuring out the dose is a little bit more complicated, and they usually don't when you give a stimulant medication, you usually know within 2 or 3 days whether or not it's the right med at the right dose. When you give these alpha-adrenergic drugs, it often takes 2 or 3 weeks before we know for sure. So in addition to those meds, so sometimes, I'll tell you my most difficult cases, when a kid can't tolerate a stimulant, and then I'll try him on one of these alpha-adrenergic drugs, and that doesn't work. There are a couple of other drugs. There's a drug called atomoxetine, which is Strattera. Strattera is a norepinephrine reuptake inhibitor in the prefrontal cortex, okay? Having said all that, that's my insecurity trying to prove that I know something, okay? Anyway, but Strattera doesn't cause tics. Strattera probably doesn't cause problems with appetite. And Strattera works pretty well, but again, you don't know the exact dose. They come in 20s, 40s, 60s, and 80s, and it often takes a couple of months before it is effective, or whether or not we know it's effective. So if you have a kid who's got a problem at the beginning of the school year and they can't tolerate stimulants, I usually don't try Strattera. I'll try an alpha-adrenergic drug like Intuitive or Capve. And then the other medication that has been shown to be effective with ADHD is an antidepressant that's called Wellbutrin. Bupropion is the generic name. Wellbutrin also, it's a dopamine reuptake inhibitor. So it's going to increase the concentration of dopamine the same way that Adderall, Vyvanse, Concerta increases the concentration of dopamine. But you don't see the presence. It only does, those drugs cause both the release and they stop reuptake and they cause release. Wellbutrin is just a reuptake inhibitor. So you don't get the same kind of increased concentration of dopamine that you might get with the stimulants, but because of that, you usually don't have tics, you don't have any appetite problems, you don't have a lot of side effects. It's not always helpful. I'm thinking right now, I have 2 kids. She actually does some tutoring for them, but I'm not going to say who they are. Anyway, I have 2 kids who take Wellbutrin because they couldn't stand the way that stimulants made them feel, and Strattera wasn't helpful to them. And they're both tolerating the Wellbutrin, and it's been very helpful to them. Now, Wellbutrin, the only side effect that you really have to worry about with Wellbutrin, and when I say the only side effect, you're going to say, oh my God, is seizures, okay? Wellbutrin at doses greater than 450 milligrams increases the risk of seizures. But if you give less than 450 milligrams, it's not a problem. I don't think I've ever treated a kid with ADHD with more than 300 milligrams of Wellbutrin. They come in 150 milligram. They make smaller doses, but the ones that last 24 hours come in 150 milligram increments. So the lowest dose that you can get as a 24-hour pill is 150 milligrams, and then the next dose up is 300. The dose after that is 450. I don't think, if a kid doesn't respond to 300 of Wellbutrin, then I'm not going to push it higher, because I don't want to take, I don't want to run that seizure risk.
So, to summarize, medication is complicated.
Medication is complicated. It's usually not that complicated. Usually what happens is you give a stimulant, and the next day I get a call from the parents and I say, oh my God, why didn't I do this 5 years ago? All right? Most of the time. But I would say that in 20% of the cases, it's complicated, yes.
Okay. Well, thank you for joining. Let me see if we have any questions.
It looked like you had some questions, yeah.
New technologies. No, we got some people saying they like the discussion, so that's good.
Okay.
Well, thank you,
You're welcome.
Dr. Ravitz, for giving that very informative summary of how to support kids who have ADHD and exploring the options for medication and what's good, what's bad.
Again, younger kids probably try to start with a non-medical intervention first. Older kids, the data is pretty strong that meds is the way to go.
And parent support training.
Absolutely.
And executive function, and executive function training.
Right. And organizational training,
Yeah.
which is part of executive function. Yes.
Okay. Thank you.
Okay. You're welcome.